dramatic increase in funding in CCBHC has really driven this model. And what it is a public payer model at this point. It requires crisis services to be available 24/7 at that clinic. And follow-up from an outpatient provider has to happen within 10 business days after an individual visits CCBHC. Now, those are two really big issues in the behavioral health environment. We've not figured out how to deliver crisis services on a nationwide basis. 988 is a step in the right direction. Crisis services at an acute care hospital, not the right model, because crisis services oftentimes don't rise to the level of what an ER is for, or even an inpatient psych is for. So we're going to address in the CCBHC model crisis services. Another issue we have is what we call the drop-off. Anytime you interface with a behavioral health patient in an acute care environment, there's a drop-off. It's a cold and sometimes what we call warm handoff to a patient. And there are statistics out there that show that upwards of 75% of the individuals with a behavioral health issue interface with an acute care provider or even a PCP don't do the follow-up step. There's no engagement from the behavioral health provider. And so we're trying to push a solution to that issue into the CCBHC. There also is a requirement that physical health be addressed in a CCBHC as well. So we're trying to address that integration of behavioral health and physical medicine.